From the JAMA Network, this is JAMA Cardiology Author Interviews. Conversations with authors exploring the latest clinical research, reviews, and opinion featured in JAMA Cardiology.
Hello, everyone. My name is Jim Udelson. I'm Chief of Cardiology at Tufts Medical Center in Boston and Associate Editor at JAMA Cardiology. Welcome to our podcast of a paper that we are publishing in JAMA Cardiology. With me today for our podcast is Dr. Paul Hess, who's the Associate Professor of Medicine at the University of Colorado, a staff cardiologist at the VA Rocky Mountain Regional Medical Center, and an investigator in the Seattle-Denver Center of Innovation. Also with us is Dr. Vinny Polsinelli, who's a T32 Research Fellow at University of Colorado. Paul and Vinny, thanks for joining me today.
Thank you for having us, Jim.
Morning, Jim. Thanks for having me.
So we're here to talk about your really interesting paper, which we're publishing in JAMA Cardiology, called Hospital Heart Failure Medical Therapy Score and Associated Clinical Outcomes and Costs. So, Paul, can you just give us kind of a big picture overview of what you did, what you found, and then we'll dive into the details.
Absolutely, Jim. Happy to do so. So, big picture, we have been very interested in the concept of value, which is defined by Professor Michael Porter as outcomes over cost. And we used heart failure transitional care as the model by which to examine value. And the outcomes of interest for us were mortality, heart failure rehospitalization, home time, and costs. And we also wanted to examine in that context variability, as well as the association between guideline-directed medical therapy and the outcomes and costs. We thought it was important to do this on a hospital level to engage a large number of stakeholders, including those not only interested in heart failure care, but also those interested in improving quality as well as costs. The first finding that we had was that there was significant variability in the hospital level use of guideline-directed medical therapy. The second major finding was that there was significant variability in the outcomes of interest, including mortality, heart failure rehospitalization or mortality, and costs. Finally, we found an association between most of the aspects of value and guideline-directed medical therapy. In general, we found that this is an important fulcrum moving forward, such that those who are interested in improving value can focus on improving guideline-directed medical therapy on a hospital level.
That's great. Thanks. So let's dive in a little bit to the details here. So, Vinny, can you just maybe set the stage for us? Why was this of such interest to you all, given what has been published in the past about guideline-directed medical therapy and heart failure? And I'll mention this, of course, is just really around reduced EF heart failure.
Yeah, that's a great question. And so, like Paul said, there's this growing emphasis on value on the health system level. And like we said, that value is defined by Michael Porter as this health outcomes achieved per dollar spent. And that was kind of agreed upon as something that all stakeholders could get on board with. And so Center for Medicare Services started to adopt this framework that launched their voluntary value-based monthly payment model. And we wanted to see that because it's overall been kind of challenging to show that this new payment model has been shown to increase value in a variety of disease states. One of them that the CMS has described is heart failure hospitalization and then the 90 days after the hospitalization. And so really, we were wondering perhaps if we could, maybe GDMT is actually improving value. You know, there's good data that it shows that it improves mortality. And as sort of like as an index, there's this GDMT score that was reported previously to be associated with better clinical outcomes. And so we wanted to see if GDMT could improve the value of healthcare.
Interesting. And so one of the things I think that caught our interest is that some of your colleagues, co-authors, had written about the relatively suboptimal use of GDMT in registries, et cetera, in the past. But you guys were looking at it in sort of the hospital level framework, which was really a different way to look at this and really interesting. Paul, can you just briefly tell us how you calculated the GDMT score to try and get a handle on how well people are being treated on their way out the door after a heart failure hospitalization?
Sure, Jim. Happy to. In the larger picture, we oftentimes in quality assessments will think about so-called opportunity-based measures as compared to all or none-based measures. In this particular instance, we chose an opportunity-based measure. We scaled it from 0 to 1, and we looked at it according to achievement of those measures in the numerator and compared that to the so-called opportunities in the denominator. We did this on a pooled perspective on a hospital level, accounting for all patients in that hospital. We did account for contraindications for guideline-directed medical therapy. And it's important to note that this score was also weighted based on the very nice data suggesting that sacubitril valsartan is superior to the ACE inhibitors. We gave 2 points for those who were given that medication as compared to an ACE inhibitor, for whom we awarded 1 point. And the other elements of therapy were effectively 2 points for each, noting that this is really focused on initiation of medications and focused on the classes of medications for whom we ought to be giving to our patients. This did not include dosing. And this is important in several ways. First is that Dr. Kittleson and colleagues recently published, even after this manuscript was accepted, the performance measures related to heart failure hospitalization. And interestingly enough, we did, in our own current paper, it did reflect that classes rather than dosing should be the primary focus at the time of hospitalization. So we felt that focusing on classes rather than dosing was important, and thankfully that has been reflected by the professional consensus.
That's good. I suppose dosing really, based on the strong HF trial, can take place quickly after discharge. But, maybe it's not fair to look at dosing at the time of discharge. So that really makes a lot of sense. Vinny, can just maybe talk about one of the main findings about the variability, which is really striking in the score and the outcomes. And then we'll talk about the correlation.
Yeah, so that was one of the biggest findings here. And so GDMT scores, again, on an index, the GDMT score ranged from 0 to 1, and the range was actually from 0.39 to 0.94 with a median of 0.66. And that's the hospital level score. And so there's a wide variability across the hospitals that participated, which were 360 hospitals. On top of that, we also had a similarly very wide range in the outcomes that we looked at. And just to put it out there, we looked at death, heart failure rehospitalization, a composite of death or rehospitalization. And then we also looked at home time and, of course, cost, which plugs into the value part. So death ranged from just 0.3 to 0.38 in the 90 days that we followed up patients post-hospitalization with a median of 0.15. Heart failure rehospitalization ranged from 0.04 to 0.63 with a median of 0.19. And then home time ranged from 52 to 84 days with a median of 70. And they're all kind of impressive variabilities, but another impressive one is the cost. The patient's cost for that 90 days, including the hospitalization, ranged from $7,378 all the way up to $51,400 with a median of $15,000.
Now, that's really quite remarkable, the spread, particularly because I don't think we mentioned it previously, but these are hospitals in the Get With the Guidelines heart failure program, right, in registry, where you kind of come into it thinking that, these are hospitals paying close attention to quality just by nature of participating in the registry in some way. And yet still, in these hospitals, you see that. And so I assume you would presume it's possibly worse in real life, every hospital, if you looked at everything. So it's really striking. So Vinny, can you now talk about the correlation between the GDMT score and these clinical outcomes that you reported?
Yeah, that is also a very exciting part of our results. So what we found was actually that higher hospital level GDMT score was associated with lower hospital level mortality, lower mortality or heart failure rehospitalization, better home time, and then also lower costs. our model did not have a significant association with heart failure rehospitalization alone. And these results in combination with variability were very exciting to us.
Yeah, so interesting. Paul, was there anything in the data that, at the hospital level sort of characteristics that associated with a lower versus higher GDMT score?
Great question, Jim. Absolutely. Turns out that hospitals that were larger, those that were located in urban sites, as well as those that were located in the Northeast, performed better than their counterparts. So quite interesting data on the hospital level. And certainly the converse is quite interesting on a patient level as well. Turns out that patients that were more likely to be discharged from a hospital with a lower GDMT score were more often women, they were more often Black patients, or they were insured by Medicare.
Interesting. So really interesting findings. And again, putting this at the hospital level as opposed to the many prior papers looking at the patient level to us made it really interesting. So let me just ask each of you in our last moment, what's your takeaway? So maybe Paul first, what's the actionable information here from the variability and those associations?
The variability to me points to the fact that on the one end, those who are performing well indicate that it's possible to do so. And on the other hand, those hospitals that are performing less well have an opportunity to improve their performance. So the variability in and of itself is quite interesting. And the paper points to that the focus of improvement in terms of the outcomes and costs, as reflected in the value equation, suggests that guideline-directed medical therapy should be an important component of that. So certainly there is opportunity for improvement on a hospital level. And there already are efforts there in terms of how to do so. This is very much in the domain of so-called implementation science. And there's a lot of excitement and interest around improvement, understanding that the hospital level reflects what happens on a patient level. Therefore, some of the more interesting studies that I've come across lately include the Implement HF study by Dr. Muthaya Vadaganathan from the Brigham. And the Yale group has had another very interesting study as well in the outpatient arena regarding alerts in the medical record coming out of JAC. So certainly there's an area of ongoing interest, and including this group of investigators as well.
Yeah, it's amazing. And Vinny, any messages that you take away from this? And by the way, congratulations as a research fellow, first author paper like this.
Yeah, thank you very much. We were really excited about the findings of this paper and the study. And I think that probably the biggest takeaway was, so far the bundled care model, there hasn't been a ton of evidence to suggest that it's actually improving outcomes in a lot of different contexts. But in this paper, we suggested, although this isn't like a randomized trial, but that perhaps GDMT prescription may actually improve clinical outcomes and lower costs, which would suggest that because, like Paul said, there is such a high variability in the GDMT score that we observed, and then what was also associated with the variability in outcomes, by improving GDMT score at the lower performing hospitals, we could potentially improve outcomes overall. And so that's what we were most excited about, because GDMT prescription is a potentially actionable thing that we can change.
Absolutely. And unlike, a lot of observational data, fortunately in cardiology, we have the randomized trials to suggest that action will indeed pay off. It is amazing. And my takeaway, the reason we were so interested in this is really, even back in the late 1990s, where there were some papers about the suboptimal use of ACE inhibitors in patients with heart failure and reduced EF 6 or 7 years after 20 randomized trials. 20 years later, your co-author, Steve Green, showed the same thing with contemporary GDMT. And now, here you are showing this at a hospital level. There's a lot of low-hanging fruit out there, which decades later, we're still struggling with the implementation, but at least we have the randomized trials to show the evidence. Well, I'd like to thank both of you. It was really, really interesting paper. Congratulations. Keep up the excellent work and go forth and implement, I guess I would say. So thanks everybody for listening. I'm Jim Udelson. I've been speaking with Paul Hess and Vinny Polsinelli about their paper in JAMA Cardiology, the Hospital Heart Failure Medical Therapy Score and Associated Clinical Outcomes and Costs. You can find a link to the article in this episode's description. To follow this and other JAMA Network podcasts, please visit us online at jamanetworkaudio.com or search for JAMA Network wherever you get your podcasts. This episode was produced by Daniel Morrow at the JAMA Network. Thanks so much for listening.